Evening all. Today I'm going to discuss a case of a 15-year-old male child who presented with us and diagnosed as acute intermittent porphyria and how we managed that case. Coming to demography, if, yeah, we are discussing a case of a 15-year-old male child resident of Jodhpur. Informant was mother, reliability was good, who presented with chief complaints of pain abdomen for 3 days and altered behavior from 2 days. Coming to history of present illness, pain abdomen, which was acute in onset in the upper abdomen, dull aching type with cloaky in nature, intermittently radiating to back, which was relieving with medication and bending forward. There are no aggravating factors. History of behavioral changes in the form of irrelevant talk and aggressive behavior. There is no history of any altered sensorium, abnormal body movements, no history of any blurring of vision or deviation of eyes or diplopia, no history of any absent or abnormal sensations over the face, no history of any deviation of angle of mouth, difficulty in closure of eyes or drooping of eyes, no history of any nasal regurgitation or nasal twang or hoarseness of voice, no history of any difficulty in shrugging of shoulders or turning head side to side, no history of deviation of tongue, no history of any paucity of limb movements, no history of any involuntary movements like flowing or writhing movements of the body, no history of bowel bladder disturbances. There is no history of any skin flushing, sweating, pallor, palpitations, no history of any spinal deformity, neck stiffness, or headache. And there is no history of any rash after exposing to sunlight or discoloration over the skin or any blisters, no history of any constipation, abdominal distension, vomiting, chest pain, dizziness. There is no history of any substance intake or drug abuse, no history of any fever, headache, palpitations, no history of malar rash, alopecia, oral ulcers, or joint pains, no history of any jaundice, vomiting, excessive fatty food intake. The child was, with these complaints, the child was initially taken to a nearby hospital, but as there was no pain relief with the medication there, he was referred to AIMS for further management. On asking past history, there is history of asthma for which child used meter dose inhaler for 6 to 7 months 2 years back, and there is history of similar complaints in the past. Child was admitted in October for around 12 days with complaints of pain abdomen and altered behavior with acute symptomatic seizures, which was secondary to hyponatremia. Least sodium recorded during that admission was 102 millicoulomb per liter. Ultrasonography abdomen done at that time showed gallbladder calculi and pancreatic enzymes scent were elevated. And there was history of alcohol intake during that time, and the child was discharged, keeping the diagnosis as pancreatitis secondary to cholelithiasis triggered by alcohol intake. Coming to birth history, there is smooth perinatal transition. Child was immunization history was unknown, and BCG scar was absent on examination. Developmental history where child was appropriate for his family history was not significant. Firstborn child of non-consanguineous marriage. On general examination, child is irritable. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. There are no neurocutaneous markers. Anthropometry is appropriate for age. On vitals, child has pulse rate of 116, respiratory rate 28, temperature 98.4, and his BP reading was 141 by 101, which is in stage 2 reading. Saturation was maintaining 100% on room air, and peripheral perfusion was normal with pulses well palpable and CFT less than 3 seconds. On systemic examination, CNS higher mental functions was intact. There are no any cranial nerve deficits. On motor examination, bulk was normal, tone was normal, and power was more than 3 by 5 in all four limbs, and DTRs were within normal limits, and bilateral plantar were flexor. Sensory examination, cerebellar examination was normal. There are no meningeal signs. Gait and spine was normal. Other system examination, respiratory and CVS was within normal limits. On per abdomen examination, all quadrants are moving symmetrically with respiration. On palpation, soft, slight diffuse tenderness was present. There is no organomegaly, no renal angle tenderness. Bowel sounds were present. With these history and examination, the differential diagnosis we were kept first possibility as pancreatitis, in which the child is having a pain abdomen which is cloaky in type, which was relieving with bending forward, and there is also history of past history of similar complaints, and hypertension which was seen can be secondary to pain, but aggressive behavior was less explainable with pancreatitis. The second possibility we have kept was cholecystitis. Favors in uh, Favoring points are pain abdomen and history of previous similar complaints. And aggressive there was no aggressive behavior cannot be explained by cholecystitis, and there is no history of any fatty food intake, or and the abdominal pain is diffuse, and there is no specific right hypochondriac pain. Third possibility we kept was porphyria, in which also neurovisceral type, as there was no skin manifestations. Point in favor are pain abdomen, hypertension, behavioral abnormalities, and history of previous similar complaints. Next possibility is pheochromocytoma. Favoring points are pain, abdomen, hypertension. Negative points are altered behavior. There is no history of any palpitations, diaphoresis. Last possibility is systemic lupus erythematosus, as the child is adolescent age group and he is having pain, abdomen, and behavioral abnormalities. Hypertension, which can be secondary to underlying renal involvement, but there is no history of any rash, headache, or joint pain. Apart from this, we can also keep a possibility of lead poisoning, which can also mimic a similar presentation like porphyria, and hyperthyrotoxicosis, which can also have hypertension, pain, abdomen, and behavioral abnormalities. But there is no history of any acute weight loss or sleeplessness. As such, history was not there. With these complaints, child was presented to AIMS emergency at arrival. Child vital showed hypertensive readings in stage 2, for which child was started on IV labetalol for around labetalol infusion was given for around 8 hours, and then as the BP readings were within control, child was taken to oral antihypertensives. At arrival, child sensorium is irritable and aggressive. Initial blood gas analysis showed hyponatremia with sodium of 115 milliequivalents per liter. With this, for this, as the child is having hyponatremia, which was symptomatic, we have started given 3% saline bolus followed by infusion. As the child, even after 3% saline infusion, child sodium levels was not increasing. So we have sent an SIADH workup, and then child was shifted to PICU. SIADH workup which was sent came to be positive. Also, fluid restriction was done. During day 2 of PSU stage, child developed one seizure episode. Even after 3% saline infusion, the serial sodium levels are not improving. So at sodium level of 107, we have considered Vaptan. We have given tolvaptan single dose. After that, there is improvement in serum sodium levels, and the child sensorium was also improved. During PICU stage, child BP readings were within normal limits, so antihypertensives were gradually tapered and stopped. And after stabilization, child was shifted to ward. During ward, his serial child complaining of pain abdomen, for which pancreatic enzymes were sent, which were came to be high, amylase lipase of 383 and 579. CCT abdomen was done as previous history of gallbladder calculi. In this admission, the CT done showed foci of resolved pancreatitis, so conservative management was done. During ward stay, child also have complaining of voiding dysfunction, which was attributed to neuropathy, autonomic neuropathy, which can be seen in porphyria. For the During ward stay, child urine porphobilinogen levels were sent, which came out to be 5.3 milligram per day. The normal value was less than 3.4. So, suspecting porphyria, child was started on carbohydrate loading, and oral high salt diet was given. During initial emergency stay, child urine kept in sunlight showed change in the color. So, keeping these possibility of so the final diagnosis was suspected acute intermittent porphyria with SAADH, which was resolved with symptomatic hyponatremia. Genetics could not be sent due to economic constraints in this child. Let's have a discussion on acute intermittent porphyria. What is porphyria? Porphyria develops due to defect in heme synthesis pathway. Heme synthesis occurs in two steps. Half of the pathway occurs in cytoplasm, and rest of the half occurs in mitochondria. Initially, glycine and succinyl CoA combine to form aminolevulinic acid, which in the presence of aminolevulonate dehydrase convert into porphobilinogen. In the presence of porphobilinogen deaminase, hydroxymethylbelane is formed, and from hydroxymethylbelane, uroporphyrinogen 3 and porphyrin 3 will form. This coporphyrin 3 enters into the mitochondria. In the presence of coporphyrin oxidase, it will convert into protoporphyrin. In the presence of ferrochelatase, heme is formed. This heme in turn inhibit this formation of glycine and succinyl-CoA combination. So this heme will inhibit this aminolevulonate synthase, which is a rate limiting step in heme synthesis, and glucose also inhibit this aminolevulonate synthase. So in the treatment of porphyria, glucose loading will help in reducing these precursors, which because of which symptoms will manifest. Coming to types of porphyria, based on the involvement and clinical features, they are divided into acute porphyria, cutaneous porphyria, both acute and cutaneous porphyria. Porphyria usually present with neurological symptoms, which include acute intermittent porphyria or plumboporphyria or DOS porphyria, which is due to deficiency of ALA dehydratase, and cutaneous porphyria, which have predominantly cutaneous involvement in the form of skin blistering and skin photosensitivity, which include porphyria cutanea tarda, congenital erythropoietic porphyria, erythropoietic protoporphyria, and hepatoerythropoietic porphyria. Acute and cutaneous are those which involve both neurological as well as skin manifestations, which include hereditary coproporphyria and variegate porphyria. Acute intermittent porphyria, it is the most common and most severe form of porphyria, which has autosomal dominant inheritance. It occurs due to deficiency of enzyme hydroxymethylbilane synthase. Usually this acute intermittent porphyria presents with non-specific symptoms and similarities with other diseases. So diagnosis is usually delayed in these cases. Acute attacks of AAP are as a result of uncontrolled upregulation of ALA synthase enzyme due to enzyme deficiency at some part of the pathway. Etiological factors for acute intermittent porphyria include triggers like alcohol, infections, fasting, reproductive hormones, and there are certain porphyrogenic drugs such as ketamine, thiopentol, erythromycin, spironolactone, methyl dopa, carbimazepine, which can trigger and leads to acute attacks. What is the pathogenesis involved in acute intermittent porphyria? As we have discussed, in this there will be a decreased in enzyme deficiency, which leads to induction of hepatic enzyme ALA synthase. Elevated levels of these precursors like porphobilinogen and aminolevulinic acid leads to the symptoms in these cases, which can also cause neurological damage. Clinical features seen in acute intermittent porphyria include a child can present with abdominal pain, which is usually severe, epigastric, and cloacae in nature. It is often associated with constipation and vomiting. They can also have psychiatric symptoms like schizophrenia, depression, bipolar disorder, aggression, and CNS involvement in the form of delirium, seizures, altered sensorium. In some cases, there can also have quadriplegia. Neuropathies, they can also present like neuropathies like peripheral neuropathy weakness, like it can also present as GBS, and they can also have autonomic neuropathies, in which there are symptoms like tachycardia and hypertension can be seen. There are associated features like hyponatremia, hypomagnesemia, and mild aminotransferase elevations and mild leukocytosis, which can be seen in these cases, out of which hyponatremia is usually most common. So, coming to how to approach hyponatremia in any emergency setting, in any case with hyponatremia, first we have to check the serum osmolality. Serum osmolality can be either normal, it can be low, or it can be high. If the serum osmolality is low, normal, it is isotonic hyponatremia. That is, this is also known as pseudo hyponatremia, which can be secondary to presence of excessive proteins or excessive lipids like hyperproteinemia, hyperlipidemia. If serum osmolality is high, that is more than 295 milliosmoles per kg, it is hypertonic hyponatremia, which can be seen with hyperglycemia or any osmotic substances like mannitol, sorbitol, glycerol, or any radiocontrast agents. If serum osmolality is low, that is less than 280 milliosmoles per kg, it is known as hypotonic hyponatremia. This should be further evaluated and treated. Sorry. In a case of hypotonic hyponatremia, we have to assess the volume status. If volume status can be hypovolemic, euvolemic, or hypervolemic. If volume status is hypervolemic, it is secondary to third space losses, which can be seen in case of congenital heart failure, congestive heart failure, cirrhosis, nephrotic syndrome, and any advanced kidney disease. If volume status is low, next we have to look for urinary sodium excretion. If urinary sodium excretion is less than 10 milliequivalent per liter, it is because of extrarenal volume loss, which can be seen in cases of GI losses, skin losses, and third spacing. And if urinary sodium excretion is more than 20 milliequivalents per liter, it is due to renal volume loss, which can be seen in cases like diuretic usage, nephropathies, or any mineralocorticoid deficiency and cerebral salt wasting syndrome. Volume status is euvolemic, that is, child is not having volume excess or volume deficiency. Then we have to check for urine osmolality. If urine osmolality is low, that is less than 100 milliosmoles per kg, the child, it can be a possibility of psychogenic polydipsia or low solute diet. If urine osmolality is more than 100, usually we will see urine osmolality of more than 300 milliosmoles per kg. The underlying causes is SAADH, hypothyroidism, and glucocorticoid deficiency. If urine osmolality is variable, it is secondary to rest osmostat, which is a type of SAADH. Coming to SAADH, what is SAADH? SAADH is a syndrome of inappropriate antidiuretic hormone secretion. It is a state of intravascular volume expansion with low serum uric acid and blood urea nitrogen levels. Usually, SAADH is a diagnosis of exclusion. It is seen in conditions like any CNS causes, like any CNS infection, tumor, trauma, hemorrhage, or thrombosis, and lung diseases like infection, asthma, and positive pressure ventilation, malignant tumors, and drugs like carbamazepine, valproate, vincristine, cyclophosphamide, and SSRIs. Diagnostic criteria of SAADH includes, we have to exclude the renal, adrenal, thyroid dysfunction, and we have to rule out congestive cardiac failure, nephrotic syndrome, cirrhosis, and there should not be any dehydration and diuretic usage. Urine osmolality should be more than 100 milliosmoles per kg, and with serum osmolality of less than 280 milliosmoles per kg, and urinary sodium excretion should be more than 30 milliequivalents per liter, and these sodium wasting should be reversed, and this hyponatremia should be corrected with water restriction. If it meeting all these criteria, we can label it as SAADH if the child is having risk factors like the causes we have discussed earlier. How we diagnose this condition? Usually, the change in urine color on standing is a good bedside screening test. This is the urine on keeping in sunlight. It will changes into brownish color. This brownish color of urine is because of porphobilin, which is the degradation product of porphobilinogen and dipyryl methanes, which will gives this brownish urinary discoloration. And this urine sample should be taken. Urine this We can also check urine porphobilinogen and ALA levels during acute attacks for diagnostic workup, but this level should be sent before giving hemin, because hemin will inhibit this rate limiting step, thereby decreasing the production of these precursors like porphobilinogen and ALA. Definitive confirmation of this diagnosis is by genetic testing for HMBS gene mutation, which is usually expensive. How do we manage these cases? First of all, we have to remove any precipitating factors, as we have discussed, like if the child is fasting or any using porphyrogenic drugs, we have to stop those drugs. And first we have to manage symptomatically. For pain, we can give morphine, dimorphine, and fentanyl. If the child is having nausea and vomiting, promazine and ondansetron can be considered. Tachycardia, hypertension can be treated with beta blockers, ACE inhibitors, and calcium channel blockers. For seizures, diazepam, MgSO4, and clonazepam can be used. Supportive therapy, as we have discussed in the flowchart, glucose can inhibit this rate limiting step and decrease the precursors, thereby symptomatic improvement can be there. So supportive therapy, we have to initiate IV dextrose, or if child is able to take orally, we have to give high carbohydrate diet. Usually 300 grams of IV glucose as D10 should be given. Definitive therapy for management of acute intermittent porphyria is hemin therapy, which is available as lyophilized hematine with brand names of panhematine and recordati. The mechanism of action is it replenishes the hepatocyte heme pool and downregulates the aminolevulinic acid synthase 1 enzyme. Apart from downregulating this enzyme, it also induces mRNA destabilization of this enzyme, thereby decreasing the production of precursors. It is usually given at a dose of 3 to 5 mg per kg per day for 3 to 5 days. As the onset of action will take time, so it should be given for at least 3 to 5 days for appropriate action. Usually hemin infusion is usually associated with thrombophlebitis. If we given in sterile water, the incidence is more high. To reduce that thrombophlebitis, it can be reconstituted with 30% albumin. But availability and cost of this drug is high, so it is a big challenge for lower socioeconomic status for timely availability of this hemin, and cost and affordability. Other therapies available for acute intermittent porphyria are liver transplantation, and hepatocyte targeted RNA interference therapy is currently under trials. How do we manage refractory hyponatremia? Hyponatremia in SIDH, the first and foremost management is fluid restriction. If child is not improving with fluid restriction, we can consider diuretics, in which also we can prefer loop diuretics than thiazides, because loop diuretics can cause free water loss. If the hyponatremia is not improving even with fluid restriction and diuretics, we have three options as described below. First one, we can consider oral urea, but as it is have poor palatability, it is less commonly used. We can also use demiclocyclone, which is a tetracycline derivative. Because of its side effects like nephrotoxicity and unpredictable efficacy and slow onset of action, it is also less commonly used. Most commonly used drug in refractory hyponatremia is Vaptans. Vaptans are V2 receptor antagonist. The available preparations are conivaptan, which is available as intravenous preparation, and tolvaptan, which is available as oral. Let's discuss about tolvaptan. Tolvaptan is a selective V2 receptor arginine vasopressin antagonist, which competitively blocks the binding of vasopressin to V2 receptors, which are located on renal collecting duct cells on basolateral side. V2 receptor inactivation will leads to inhibition of the synthesis and transportation of aquaporin to water channels into the apical membrane of the collecting ducts, and thereby decreasing the free water reabsorption. This tolvaptan undergoes hepatic metabolism, and its half-life is 6 to 8 hours. These tolvaptan specifically have greater selectivity for V2 receptors, and less selectivity, less effect on V1A receptors, which are located on blood vessels and cause vasoconstriction. And this tolvaptan has no action on V3 receptors, which are located in anterior pituitary, which are involved in ACTH production. What are the recommendations of tolvaptan? When to give and in what patients we have to consider giving tolvaptan? This tolvaptan is mainly indicated in hospitalized patients and in only some selected outpatients. The first indication is if the child does not respond to fluid restriction for at least 48 hours, we can consider giving tolvaptan. It can also be given as first line therapy in selected cases where there is a clinical need for prompt correction of hyponatremia, such as if any patient surgery is planned and the child is having hyponatremia. For to render the patient early to fit for surgery, we can give tolvaptan. And also in some cases, in some patients in whom chemotherapy should be started with drugs which can cause hyponatremia by themselves, such as platinum based agents, we can consider giving tolvaptan. Third indication is we can also give it as first line therapy in patients who are unlikely to respond to fluid restriction, such as at diagnosis if the child is having urine osmolality of more than 500 milliosmoles per kg. These patients are bit difficult to improve with fluid restriction alone. In such cases, we can consider giving tolvaptan. For chronic use in outpatients, such as either refractory or cannot adhere to other treatment modalities like patients with lung cancer who require frequent admissions. In such cases, we can give tolvaptan on OPD basis, but with strict monitoring. At what dose and how to give this tolvaptan? This tolvaptan dose was should be given at a dose of 15 mg if baseline serum sodium was more than or equal to 125 milliequivalent per liter, and at a lower dose of 7.5 mg if serum sodium is less than 125 millimole per liter. Because if we are giving less dose if serum sodium is low, to prevent high rate of overly rapid correction in severe hyponatremia, which can leads to osmotic dysmyelination syndrome. And tolvaptan is contraindicated in conditions if we are using strong CYP3A4 inhibitors such as ketoconazole, clarithromycin, or protease inhibitors. These drugs should not be administered along with these drugs. and it should be administered at lower doses if we are using moderate CYP3A4 inhibitors such as fluconazole, erythromycin, diltiazem, or verapamil. How to monitor, what things to monitor while giving tolvaptan. Monitoring is very important while giving tolvaptan. So during tolvaptan administration, serum sodium should be monitored every 6 hourly. You have to take baseline sodium level, and at 6 hours, 12 hours, 18 hours, and 24 hours after the initial dose. We have to check input output balance strictly at every 2 intervalli. If sodium rises 6 millimole per liter in 2 hours, 6 hours, or 12-hour sodium rise exceeds 8 millimole per liter, or 18-hour sodium rise exceeds 10 millimole per liter, or urine output exceeds 200 ml per hour for 2 hours, we have to intensify the monitoring. We have to halt further correction by administration of intravenous infusion of dextrose D5% at a rate equal to or urine output, or alternatively we can give desmopressin 2 microgram as a start dose intravenously, and after 8 hours. This is just to prevent a rapid correction of sodium, which can lead to central pontine myelinolysis. If serum sodium rise is more pronounced, we can re-lower the sodium levels using two methods. First, we can give intravenous infusion of D5 at a rate of 6 to 10 ml per kg over 2 hours, and then we have to repeat sodium levels. If till sodium is not in target range, we can continue infusion till we achieve target sodium levels, or else we can give desmopressin 2 microgram intravenously plus an intravenous infusion of D5 in water at a rate of 3 to 5 ml per kg over 2 hours, and we have to repeat sodium levels, and then similar to previous condition, we can continue on infusion till target sodium was achieved. So when to consider second dose of tolvaptan? Sorry. If first 24-hour serum sodium rise was 9 millimole per liter or above, we have to withhold the next dose. If rise is 5 to 8 millimole per liter, we have to continue at the same dose. If the rise is less than 5 millimole per liter, we have to titrate tolvaptan dose by doubling the dose. If the first dose was given at 15 mg, we have to give the second dose at 30 mg. If first dose is given at 7.5 mg, we have to give second dose as 15 mg. So these are the case reports showing acute porphyria, which is presenting as an unusual case of quadriparesis, hypertension, recurrent cyclical abdominal pain, and seizures. And this is a case report showing presented as posterior reversible encephalopathic syndrome. One case report showing acute intermittent porphyria presenting as GBS. These are my references. Take-home messages are high clinical suspicion is key to early diagnosis. Algorithmic approach to ease the diagnostic dilemma, which is usually there in the evaluation of hyponatremia, and conservative management of acute intermittent porphyria with carbohydrate loading in hemine unavailability in resource limited settings. Meticulous monitoring and timely intervention is necessary for severe hyponatremia, as it is life threatening, and use of Vaptans can be life saving in refractory hyponatremia, and a topic of interest for research in children. Whatever literature available, the doses, all studies are done in adults. None of the studies were done in children. So it can be a topic of interest for research in children. Thank you.